Hello everyone, today's video is another Q&A video talking today about using ozone for mycoplasma, talking about genes that relate to lower vitamin D propensity, and also talking about whether low-dose immunotherapy can be used to help with hay fever. As per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. And if you don't mind taking a quick moment at some point to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. So the first question here, someone's DM'd me on Instagram and is unfortunately having a issue with mycoplasma. I think it's a mycoplasma ureaplasma issue, and just asking for me to post a video about using ozone because that's one therapy they're able to access in their home country, and so I said I would post a video about it. Of course, not able to give any direct advice over social media, but just speaking about it academically, I'm happy to post a video about that. So when it comes to like urogenital mycoplasma issues, I really don't have any direct experience using that. Systemic ozone can be helpful for mycoplasma in general, like if there's mycoplasma pneumonia that's affecting somebody systemically, affecting their nervous system, etc. Can be potentially very helpful. I've seen it be very helpful in cases for helping to improve energy, reduce pain, reduce brain fog, etc. Intravenous ozone can potentially be could potentially be helpful for more of like a urinary tract related or bladder related mycoplasma issue. I just haven't used it in practice for that purpose. Usually we work with oral herbs. Patients are maybe taking antibiotics. We're using biofilm disruptors, low-dose immunotherapy. Like those are the main tools that I use, and they generally work well. It's not always a fast process. It can unfortunately take quite a while, especially if there's biofilms to break things down. Sometimes several months in really tough cases or recalcitrant cases, or tenacious cases that could also be recalcitrant, I suppose, in some cases. But I have not used ozone in those cases in particular. There is an application of ozone, which is not something I use in my practice, but it's something that I learned about many years ago from Dr. Frank Schallenberger. He's kind of like the godfather of ozone therapy in North America. A really, really brilliant doctor, and he during one of his training courses, he taught us this protocol for doing ozone bladder installations. So for folks with interstitial cystitis or other chronic bladder issues, there's actually methods where you can work with a doctor to basically have a catheter inserted into the bladder and infuse ozone directly into the bladder. And he was, my understanding from his course material is that it can be really, really helpful in chronic bladder issues. We do know that ozone at high enough concentrations is able to break down biofilms. I don't know that you can actually get high enough concentrations to break down biofilms using a system like that. Some of the studies that I have seen, petri dish studies, like they're literally bathing the bacterial or yeast biofilms. It was a candida study that I'm thinking of, actually a candida biofilm for I think like half an hour with ozone gas. So you're just never going to get that in a biological system to work. So ozone has the antibiofilm properties, but they're just not, I don't know that we're able to use a strong enough dose of ozone to make that actually biologically applicable in humans. If you're a petri dish, then you're all set, but if you're a human, maybe not going to work. But ozone, just with its anti-inflammatory properties, tissue healing properties, could be really helpful in that regard. So I really don't have any significant experience with the bladder installations, but that is something. So if I lived in a country and I had access to nothing except for ozone, I might talk to my doctor about whether that might be applicable for me. So yeah, I'm sorry I don't have better news about it. I'd love to be able to post a video saying ozone is just incredibly effective for that condition, but I just haven't really had much. I don't really have clinical experience to speak to that over and above what I've already said. So I wish you all the best with getting better, and I hope that you have good results ASAP. The next questions here. Someone who's posted questions on my videos many times, and always happy to see them, and they always say nice things in the comment section about me as well. So I appreciate this commenter very much for the questions and nice words. So the question is it true there's a gene that makes some people more susceptible to having lower vitamin D amounts? So what I've found in my experience is if folks have in my patients, if folks have mutations in what's called the VDR TAC, TAQ gene, or the VDR BSM gene, then that seems to clinically correlate with folks needing to take more vitamin D than the average bear. So the VDR gene is the vitamin D receptor gene, and when that gene is mutated, then it affects the structure of the vitamin D receptor, and that might make it less able to bind to vitamin D. Now, to be perfectly honest, I have not gone down the rabbit hole of looking at the research literature to see, is this something that's been research validated, that this is a thing that everything I just said is what is the case physiologically, but have there been any studies showing that folks with these mutations need more vitamin D than the average bear? And if so, is that because the vitamin D doesn't bind as well? I don't know if that research has been done, but I've definitely seen that in practice in many patients over time. So I think that is, I consider it to be predictive, but I don't know if there's research actually backing that up. In terms of genes that might actually cause someone to have a lower vitamin D amount, so things that would interfere with vitamin D absorption or whatnot, I'm not sure if there's any genes that look at that, but definitely seen that correlation with the VDR genes, especially at those locations. You can see genetic reports where they test other locations on the vitamin D receptor genes besides the TAC and the BSM, and I'm not really sure if those are actually that clinically important or not, but that's just what I've seen in my practice. The last question here by the same individual is, can low-dose immunotherapy be used to help with hay fever? So a little bit of a semantics thing here. Low-dose allergen therapy, which is the parent therapy of low-dose immunotherapy, has a long-standing history of being used to help folks with lots of different environmental allergies, including hay fever, and it can work really, really well. The general numbers that are batted around in the low-dose allergen therapy, low-dose immunotherapy community is that about 80% of standard cases are going to see a response with LDA therapy for standard allergies. And I would say that my experience with LDA, and I've been using it for about 11 or 12 years now, it mirrors those numbers. So it doesn't cure every case, but it can be really, really helpful. We have been kind of going, we collectively, me and one of my colleagues, have been looking at sublingual immunotherapy, and the research is quite good on that. And so, because we do have some patients that don't, just unfortunately LDA, LDI doesn't work for them. So we've been kind of looking at bringing something else into the clinic to hopefully help those cases that are not helped, that 20% of cases, standard cases, who aren't helped by the LDA slash LDI. And so sublingual immunotherapy is something that we've played with a bit before in years gone by. Played with lots of things over the years in practice, but it's something we're kind of taking another look at. So maybe I'll post another video at some point if we start working with that again, and kind of see of the patients that don't respond to the LDA therapy, what percentage of them seem to then respond to the sublingual immunotherapy, also known as slit therapy. That's it for today. I hope that this information was of use, and if there's any questions or comments, just post in the comment section below, and I will do my best to answer as soon as I can.